Welcome everyone. This is Dr. Sharad Jaitly from New York, your cardiologist on your favorite website, MuniMeterHealth.com, which is dedicated to teaching you about, educating you about the human heart and its illnesses, and of course, keeping one thing in mind, that is patient education and medical education combined together produces the best clinical outcomes from one end of the globe to the other. Thank you again for watching MuniMeterHealth.com, because the premise here is to freely disseminate the information about the heart and its illnesses to everyone at no cost. So without any further ado, I'd like to delve into the matter of the subject, as I always say, and the matter of the subject today is coarctation of the aorta. Now, coarctation of the aorta implies, obviously, it's a congenital condition, so let's understand that first. And because it's a congenital condition, so the child is growing and will have developmental, obviously manifestations. The clinical features are typically the upper body is fully grown, if you will, and the lower body, the lower half of the body is not. So that is not, so it's weak, there'll be weak pulses, there'll be hypertension or high systolic blood pressure in the upper extremities, and there will be low blood pressure in the lower extremities. So that's one of the sine qua non, if you will, of the diagnostic features that we are getting into now. There will be systolic murmurs throughout the chest, and more so between the interscapular region, if you will, and that's because of the coarctation actually exists right next to the ligamentum arteriosum, or after the left subclavian artery has taken its shoot off. So let's draw a schematic here. Here's my favorite cartoon, if you will, my heart here. And we are not going to concentrate only in the aorta, so I'm not going to draw the rest of it because that's not within the scope. Now here the aorta arches up, goes up like that, if you will, and it gives off a branch, which is your right brachiocephalic. Then it gives off a branch, which is your left carotid, and then it gives off a branch, which is the left subclavian. And right next to the left subclavian, soon after that, this is where the ligamentum arteriosum exists, and the coarctation occurs because of this region, because that is stenosed. So there will be a stenosis, and then that stenosis persists. Sometimes it lasts for a little longer, for a couple of centimeters, and then there is a post-stenotic dilatation, and then subsequently the aorta starts descending. So what have you seen? You have seen that one, it is located distal to the left subclavian. I'll do that left subclavian here. Okay, this is your left carotid, and this is your right brachiocephalic. Okay, so right brachiocephalic, left carotid, and the left subclavian. So soon after the left subclavian, the ligamentum arteriosum is attached here, which is the remnant of patent ductus arteriosus. Remember the ductus arteriosus that was patent during the childbirth or during the fetal growth, because that's required. That's how the circulation goes. The oxygenated blood comes into the aorta and supplies the lower half of the body. So the key is that seals off after the birth, and then that becomes the ligamentum arteriosum, which is present in all. But in coarctation, it tends to narrow this part. Now, there is a syndrome called Turner's syndrome, and that's highly prevalent in the women. But in general, coarctation is more in men than in females, but Turner syndrome is more in females. Remember that? And it is linked to a chromosome X45, if you will. So there is an X chromosome 45, which is linked to Turner syndrome here. Bicuspid aortic valve is frequently present. Left ventricular outflow tract obstructions can be present here, but a bicuspid aortic valve leading to aortic stenosis, obviously, as the child is growing into adolescence and young adults, is a given if it left untreated. So these are some of your features. Hypertension, as I said, in the upper extremities, systolic murmurs throughout the chest is also from the collaterals, which are going around the chest. Now remember, here is a chest, if you were to look at, The ribs are obviously, I'm going to just show another color here for the sake of the ribs, if I may. Yeah. So the ribs are going down in this fashion, and as the ribs are going down in this fashion, there are intercostal vessels which are right next to these ribs, and they show notching. And the notching is at the undersurface of these ribs, and that is seen on the X-ray as well. So the chest X-ray is pretty much diagnostic. One, you will see a figure of 3 sign. What is this figure of 3 sign? You have a dilatation, indentation, and a dilatation here. You see that? That becomes a figure of 3 sign. So that's figure of 3. That is in the descending aorta. One sees that. LVH will be present. Obviously, the left ventricular hypertrophy will be there. Then you will also have, in addition, these intercostal rib notching, if you will. And rib notching is almost a diagnostic, because if you see that, you have the diagnosis of coarctation of aorta by chest X-ray alone. Now, there will be other, let's move on to the next page here, if you will. ECG will be showing the following. It will obviously showing the LVH pattern. And remember, these are in children and in young adults, because that's where the coarctation is diagnosed by a significantly high blood pressure, as a matter of fact, because these individuals are hypertensive. And of course, they have heart murmurs throughout the chest because of the intercostal collateralization that occurs under these ribs, specifically so under the scapulae. So that's where the murmurs will be heard. So left ventricular hypertrophy, left atrial enlargement in the ECG. Echo is almost diagnostic, especially if you do it from the suprasternal notch approach. And if you do the suprasternal approach, obviously that will show the coarctation right there. And the coarctation is, as I said, it will be seen as an indentation within the aorta. So the aorta is here, and then indents, and then indents again, and then it dilates again like that. So that's what is the figure of 3 sign, if you will, because this is radio opaque, and that becomes like a 3. So that will be seen on the echo. You can see the extent also, and the pressure gradient is very important, and more than 30 millimeters, just so that you know, is considered as significant. So that's very important to know the pressure gradient here, and that is approximately 30 millimeters. CMR is diagnostic because it will tell you not only the extent, but the type of stenosis, and then the length of the stenosis, how long it is, because that's how you guide the further surgical therapy. Now, coming to now the complications, for instance, the complication, if you leave it untreated, the complications are following. One, you can develop an intracerebral hemorrhage, very important, complication, which needs to be, it's dreaded, unfortunately, obviously, because of the circle of Willis, so where the arteries can actually start dilating. Remember, everything is growing within the body in a young pediatric age, as well as in the adolescents. So the intracerebral hemorrhage occurs in the circle of Willis, which is sitting in the brain circulation right next to the optic chiasma, if you will. So it's a very, very serious. Then headaches are very common. Seizures are very common. You have all these complications that I can go on and keep listing. But remember, hypertension is sort of is the give, and that gives away the story here right away. So now surgical treatment is the way to go, because you gotta surgically repair the aorta. So one is repair of the aorta with a Teflon graft, etc. You can use the graft here and put a new aortic graft here, and you will be able to do that. Or else you'll have to do the balloon stent. So the balloon stent is equally as important. Now, residual stenosis or coarctation again occurs in these individuals. Just keep that in mind. That's one of the post-op complications. But invariably, you can cure the patient, but sometimes patients still require antihypertensive therapy. So hypertension therapy will still continue, if you will, and that may have to be still continued. So in a nutshell, the echo is diagnostic. ECG findings are LVH and LAE. Chest X-ray can be diagnostic if you have all of these present, figure of 3, and the rib notching, if you will. As I just explained, the rib notching is because of intercostalization or collateralization of the intercostal vessels. And figure of 3 is because of the indentation from the ligamentum arteriosa, while there is a pre-coarctation dilatation and as a post-coarctation in the dilatation as well. So remember, hypertension and upper extremity should be a good clue to tell you about in a pediatric and an adolescent age. And specifically, there'll be a radiofemoral delay. I forgot to mention in the physical findings, there will be a radiofemoral pulse delay. That means the radials will be felt early and then ephemeral because of obvious reasons. And the pathogenesis of coarctation, just remember, it's probably mechanical in any case, but it's also because of vasoconstrictor response that is occurring throughout the body and throughout all the arteries. So vasoconstrictor response is very, very important in the mechanism of the hypertension, if you will. So just very important, and therefore vasodilators are very, very helpful, but only after you've treated this individual with the surgical or by the balloon stent mechanisms that we have currently available in the United States and everywhere. Okay, I thank you for your attention on MuniMeterHealth.com. This is your website to teach you about the heart. So long, this is Dr. Sharad Jaitly. Until the next.